So while we're waiting for people to line up with questions, and I want to encourage you in the audience, I know quite a few of you, and I know a lot of you are yourselves innovators involved in Pioneer ACOs and bundled payment arrangements, so I encourage you to ask questions and share your thoughts as well. But I wanted to just sort of ask a first question to the panel. You know, as we think about how we're going to evolve from where we are today with home health care toward better use of home health care in the future that's appropriate and optimal, I'm wondering what kind of healthcare delivery system and policy changes you think are really needed, particularly for what we call traditional Medicare. And I noted that some of you are operating under a CMMI grant or in a CMS program. And so in particular, I'm really interested in whether there are key Medicare rules or regulations that were waived or altered that are enabling you to do what you do.
Well, I would offer one thing. I think that, especially given the last presentation, that CMS needs to recognize functionality as an important component of keeping people healthy, and therefore needs to reimburse for home care, home health aides supporting Medicare beneficiaries' functional needs, which they don't do today. They only reimburse for medical. Medicaid does, but not Medicare. So for older folks whose acute care utilization and cost is driven by the lack of their functionality and need some of the support just discussed, we need to have a reimbursement stream for that.
I think that from the perspective of the bundled payment, and I'm specifically talking to the BP3 model that we're doing with 50 hospitals for congestive heart failure, I believe it's really allowed us to be much more creative. Number one, we're not bound by homebound in the post-CHA piece of the 90-day bundle. And some of the things that we have employed are we use pharmacist consultant that do sort of simplification of dosing schedules, because some of our recipients have said, I take meds too much, too often, all day long, and they actually work with the PCP on simplifying dosing schedules. The other thing too is having a home-based NP practice. One of the things was a challenge was that unless they're a PCMH level 3, we didn't see a lot of open access scheduling in the city of New York in terms of PCP appointments. So we offered that as the PCP to say, well, if they couldn't see the person right away, for that urgent situation, we can provide a home-based NP to be their eyes and ears, and they seem to really appreciate that from a consultative standpoint. So in the post-CHA piece of the episode, and really that's been about day 38 to day 90, because the length of stay we were seeing on the home care side was up to about day 38. By rerunning the OASIS and getting another predictive score, we could actually then target for, specifically, and you'd be surprised how the risk score changed from start of care and then rerunning it, and then targeting the specific interventions around things like long-term medication adherence and things like that. So.
All right, I see a line at the mic. Peter.
Well, first of all, I feel less like I need ECT now, so that's really very good. One brief comment and then a question. My comment is about the chronic conditions framework. I would like to propose, for the record, that we advocate just leaving it behind us. When you talk about 2 chronic conditions, 75% prevalence of hypertension in the geriatric population, 80% prevalence of osteoarthritis. So everybody has 2 chronic conditions, right? We need to talk about people with function-limiting chronic illnesses, right? And because the chronic conditions rubric is getting in our way. Everybody has 2 chronic conditions. I would go around the room, probably most of the people in here have 2 chronic conditions. That's a comment. My question is about scope creep. So my family, we get into projects, and You know, I'm thinking back, there was an earlier comment about the channeling demonstration, otherwise known as the National Long-Term Care Demonstration. Everybody who's old enough to remember how that came out remembers how it came out. The part where you added a few $100s of extra services was even worse than the part where you just coordinated care, and that's ancient history. The question is about scope creep. So my brother and sister and I are starting a project. You gotta, there's a strict rule, you have to manage scope creep. So how do you guys keep the do-gooders, who are us, from going and fixing stuff more than what needs to be fixed? Because there's always more stuff that needs to be fixed than what you can afford to fix.
Any takers?
So because of our CMMI grant, we had to be very precise, and we're continually monitored and evaluated to staying the course, to playing by the rules. And then the other piece is we went back to whoever was talking about, you know, the competency and the skill set. We don't want to expand faster than we're able to produce a high-quality, reliable service in the home. So, you know, I think if you stick to some basic things like that, you're pretty safe. But I know what you're talking about.
You know, so, I mean, we have, the way we approach that is, so internal to Humana, when we provide a clinical service, a care service, the health plan has to pay for it, just like Optum might be working with a health plan that's not United. The health plan has to pay for that. So we have best practices, and we have protocols that define the amount of service, the amount of time, and the cost, which the health plan pays for, which allows us to do certain things. So on a per member per month basis, we have rules around what can be done.
Thanks. I thought this last session was really, even though at the end of the day, just wonderful. And, you know, from Peter Bowling's presentation and all of you, I think really showing some of the seeds of home-centered care that are blossoming throughout the country and through businesses. And I just had a question. A number of your initiatives or your organizations have been born out of mergers in some instances, acquisitions, vertical integration of multiple large service lines and service providers. And I'd like to know, to what extent do you think that that in and of itself, the additional consolidation and integration or vertical integration of home and community or in post-acute services, in some instances, will drive value? How important is that type of integration in and of itself, in your opinions?
Well, having been somebody who was acquired, I think that actually it's very important. I was very proud that Humana recognized the need for in-home care management and care support, and acquired Senior Bridge, which was a New York-based company, which became, as part of Humana, Humana at Home. Ron can talk about United. So I think that we would never be able to have scaled our care program for 30,000 transitions nationally, and we're taking care of about 40,000 in-home care management members on a national level. We would have never been able to scale that without the power of Humana and the economic backing of that scaling. Now, our programs, similar to Care Plus, have about a 3-to-1 ROI. But you know, it's been a real pleasure to work for Humana and see them support this kind of care, and then based on that, decide to go further and further into the home as where the glue to hold health and hold the member whole will take place.
I would say that it's been very important on sort of multiple levels. One is around alignment. A second is around sort of, you know, financial bottom line. A third is around communication, you know, sharing medical information. Another aspect is a sort of one-to-one, we're going to do this across our system. To be able to do that with one entity, you know, I could imagine that we could have worked with, you know, several or even one or two large VNAs in eastern and central Massachusetts to try to duplicate what we've been working on. But I think each of those barriers would have to have been worked out, information, finance, alignment, to the point where it gets, it would be almost burdensome to do. So I think it's been very important.
Yeah, this experiment kind of played itself out in the 90s, but it didn't finish itself out because a bill never got passed. So I don't know if the bill is going to make that happen this time, but there's a blurring between the providers and the plans. So here you have two organizations that are doing provider business. I'm in the provider business. We're in a plan business now. The 90 providers that got into plans failed, and the 90s plans that got into providers failed. There were a lot of disasters. And the question is really, what's our industry going to be left with at the end of the day if we go through another set of failures? That's my biggest concern as a caregiver. Is this blurring of lines could be good, but we'll have to see.
Oh, we've got a question.
And I think my experience, probably similar to what Eric said, we also, the old legacy Evercare program, acquired a company called Inspiris and gave us a lot of capabilities both in the external payer market outside of United, but also I think the ability to provide access to a very successful delivery model powered by Optum that could reach a lot more people, I think is really the key to it, and where I think it is driving value. It's not without its challenges, obviously, when you bring organizations together that operate on different platforms, trying to bring all that together into one program. It takes time before that value can actually be realized, but I think ultimately probably a good thing.
Terry O'Malley, sorry.
No, I just had one other comment. I think from the standpoint and not being an acquired or we've been an acquiree, that we learned over time through sort of being a provider and a plan to be a lot less transactional, what I call a lot less transactional and more care management focused over the longer term. So for example, our call center, typically it was a home health type call center, and it has evolved into a 24-hour kind of call center that supports the plan and the provider side, and whose first reaction isn't call 911. In reality, that's, you're moving from a real transactional mindset into a real longer term care coordination mindset. And I believe the way our organization has evolved has really helped that.
Okay, Terry O'Malley from Partners.
Terry O'Malley, Partners Healthcare, Boston. First of all, it was great to finish with the patient's priorities and getting what they need done in their home based on what they feel is most important. And it was a great bookend to Mr. Martinez this morning. So I thought that was a really striking opening and closing. And the question I would ask the group is, it seems that scale is so critically important. And you guys have all, in very different ways, created systems that integrate care across multiple different sites and really different models, the medical and social. So the question for the rest of us who don't have the scale of Humana or United or Atrius or Sutter or VSNY, what is it that we can take from what you've done and really implement on a much smaller scale? Because that's how the rest of this is going to work out. You guys will carve up a lot of the country, but you won't carve up all of it. So what's going to be left for the rest of us to do? Thank you.
Well, one thing I would say, because even though there may be some disagreement about this, I think that you can scale by telephone pretty well. So if you use telephonic and telehealth care coordination and support that in various ways, you can have a pretty successful program.
From my perspective, and I did say in my presentation, we often view my department or division as a laboratory, and in no way, shape, or form should you take from this that we started off big. We did not. So it's a team, then it evolves, then it gets bigger and everything. But fortunately for the organization, we can test models of care, but you shouldn't take from this that we snapped and were this tremendous part of the organization. It was a small, what I call laboratory department that evolved.
I think technology, it's not going to be the end-all be-all because the warm touch is still a very critical component, but there's ways to scale using technology, sensory devices, video. We're piloting high-definition video visits. Santa Clara County, it's right in our backyard. We got Apple, Cisco, we got everybody testing everything. You wouldn't believe the stuff that's coming out. It's going to eliminate me in some ways, but I hope not.
Yeah, I agree with that actually, which is why I mentioned technology. So you can do something simple, interactive voice response, IVR. So we're testing IVR on congestive heart failure patients. You could visit them in the home, or you could have them with an electronic scale that records their weight and report it, or you could simply use automated, pre-recorded phone calls, which are very cheap to do, and ask them to self-report their weight. Now, some people say, oh, they won't really tell you their weight, but they do. And so you can accomplish a lot of this with technology that's very scalable.
And I think there's great power in being able to do the right thing for patients and being able to track that using data. And so, what I would say to, any entity that doesn't have the scale is start to track what you're doing, capture the data. There's power in that. And if you can show that you're doing things that are providing better care, quality is improving, costs is going down, I think you've got something that you can bottle up and, it can only grow from there.
I know the question wasn't to me because we've not scaled, but a lot of what I talked about you can do for free. Just rephrasing the questions about function, for example, and the person's goals. And then in terms of the home repair, it's going to be so cost effective. It's going to be such a good return on investment that as long as places are a little bit capitated, I think that will really work out. And also, there's a whole aging society of people who are healthy, who are not in the 5% costing so much money, who are eager to do things like help fix up people's houses. And we need to do a better job of harvesting, using the people who are healthy, who are older adults, who have got some time, who want to do things like put a railing in on someone's house.
I'm going to just ask a quick question to the panel because I know we're running out of time. The last question I wanted to ask was whether, beyond the policy changes you've mentioned here today that you think might be critical to propel your models, what approaches to payment do you think might be critical in terms of reform going forward into the future?
Well, I think everybody sort of has this on the tip of their tongue, but I believe in capitated payments so that organizations can make the best decisions to support the health of their members. And if you do what's right, your organization will do just fine. So I think capitated reimbursement has to replace fee-for-service.
Yeah, and payment for value, but the point that I would make, from the perspective I'm coming from, is that access to a program like ours is limited today. You have to enroll in a health plan, or you have to be a patient of a particular provider group. And I'd like to see programs like this that demonstrate really strong results to be more accessible to the hundreds and thousands and millions of people who don't have access to them today. So direct to government types of programs.
Yeah, if you've been watching the MA growth, it's up to 15.2 million lives. It's 30% of the American beneficiaries. In California, it's 40%. And it's growing at 1 million a year, and it's been like 5 million over the last 6 years. There's one catch, though. If you read the ACA bill, that's where I was here talking to Ways and Means a couple months ago, the cuts baked in through 2020 will take it down to 95% of Medicare. So none of the plans are going to offer it. None of the providers are going to take it. So there's a political debate going on in this town about the Medicare Advantage cuts, and it's very critical. So now every time the cuts come up, they get scaled back because there's a lot of voters in those cuts, and it's getting larger. So I support capitation. Now, not everybody's going to join up for an MA plan, right? And in which case, how are you going to get the fee-for-service beneficiaries in? We're experimenting with a quasi-PM for just chronic care within PPO models, so that you define through attribution in a PPO population who are your patients that you want to maintain and really, offer them services and care for them. And then the plan, and it could be the federal government or the state, gives you a PM for those covered lives that are agreeable by some formula. Because I don't think all the fee-for-service PPO are going to just join HMOs.
Any final thoughts? All right, I want to thank our kind panelists for sharing so much of their work with us.